Welcome. My name is Christina Davis. I'm the director of the program on U.S.-Japan relations, and we are very excited this morning in the United States, this evening in Japan, for those of us who are joining us from Japan, to have a panel on the most important topic. As we all in the world face a pandemic, we must learn lessons from the experiences of different countries. And so we are very happy today to take an opportunity to look at one of the countries that has had a much more successful response in trying to control the pandemic. Of course, there are problems as well. So we can look at how Japan's response to COVID-19 offers lessons on what has worked well, areas where there may be more work to be done, looking broadly from a policy perspective and an academic perspective. It's really wonderful that we have a scholar to lead us through this discussion, and I will introduce Michael Reich, who is well known to us all, of course, at Harvard as the director of the Takemi Program to International Health. He is the Taro Takemi Research Professor of International Health Policy at the T.H. Chan School of Public Health. Now, we are also very proud that Professor Reich has been the U.S.-Japan Program Associate in 1982, and he has also been a scholar of political economy, having received his political science PhD from Yale, and brings deep expertise in politics that informs his analysis of public health and has allowed him to engage in the forefront of the critical issues of access to public health. He has several books published, Harvard University Press, on access to health, public-private partnerships. He also is publishing in the leading journals, Lancet, on critical issues that we all must be giving attention to today. And we're very fortunate to have him joining us to moderate this program, bringing to us a great panel to discuss how Japan has responded to COVID-19. Since our time is short, I'd like to pass things over to Michael now.
Thank you, Christina, and it's a pleasure to be here. I'll give you the global Zoom greeting. Good morning, good afternoon, good evening to everyone. I'd like to particularly thank the Program on U.S.-Japan Relations for organizing this session, and to thank our three distinguished panelists for taking the time to share with us their thoughts on Japan's response to COVID-19. I think we're all aware about the influence of politics on the pandemic. And we're going to get three different perspectives today to try to explain the Japanese puzzle. Why has Japan done well in dealing with the pandemic compared to the disaster that we're experiencing in the United States? And what are some of the ongoing problems? Our first speaker today will be Senator Keizo Takemi. He is a member of the House of Councillors. He was first elected in 1995. He's had various leadership positions. He's head of global health strategy in his party, the LDP, and has had a series of both national and international positions related to global health. He is Japan's leading politician and policymaker on global health. He'll help us understand what has happened in the Japanese government to respond to COVID-19. I'm very pleased that Margarita Estévez-Abe will join us. She's an associate professor in political science at the Maxwell School, Syracuse University, and works on comparative political economy of advanced industrial countries. She's particularly interested in how political and economic institutions affect both political processes and everyday life. She's done some fascinating work and written a really good paper on what has happened in Japanese homes for the elderly to respond to COVID-19. This is really important, especially there was just an article in today's Boston Globe about how in the state of Massachusetts, we've done a very poor job. 2/3 of the deaths related to COVID-19 happened in nursing homes and long-term care facilities here. And the third person is Professor Goto of Health Information Epidemiology at Fukushima Medical University. Her main research interests are the prevention of unintended pregnancy and parenting support. She's worked with local communities, both in Fukushima, as well as in Ho Chi Minh City in Vietnam, and has strong interest in the role of public health nurses. And she'll talk with us today about what has happened in Japanese communities and health centers. So we have something about the top-down government response, something about nursing homes and the elderly, and something from the bottom-up communities and public health nurses. This is an advertisement for the next seminar in the US-Japan Relations program next Monday. And we have a few points of Zoom etiquette and housekeeping, the most important being, please keep your microphones off during the presentation and discussion unless you're speaking. If you want to make a comment after the 3 presentations, we'll have time for a few comments. I hope they'll be brief and to the point. And just a note that this is being recorded. So thank you very much. And with that, we will move to the presentation from Takemi-san.
Very kind introduction of my talk. I'm now also the chairperson of the governance for infectious diseases in the headquarters for the coronavirus, the COVID-19 of LDP. And recently, I officially proposed our the ideas for the fundamental reform for the Japanese the system for emergency, specifically focusing on infectious diseases. So now, next slide, please. Everybody now knows that Japan's, the case of the infections and also the number of deaths is very small, rather than the other countries in Europe and the United States of America. The interesting thing is that even though those are the outcome of the number of cases is such a small, but still the popularity or approval rates of the government, the policy toward the infectious diseases is still very low. Why this sort of things happened in the Japanese, opinion research? This is one of the very interesting the subject we have to clarify. Now many persons mentions that we have a kind of a factor X, but we don't know what's a factor X. But now maybe the Abe-san maybe clarified the one part of the factor X through her marvelous the presentation after myself. Please, next slide. And this is the very clear fact that over 80% of the confirmed deaths are in the 70s or older, and the case, the fatality, the rate, which indicates the ratio between the confirmed deaths and the confirmed cases is 2.4% for the 60s, but raised to the 7.5% in the 70s. And 17.4% in their over 80s, and only 8 deaths under 30s. This is quite clear that how the risks is constantly focused on those elderly population. Next, please. And unfortunately, there are so many things happened for the decision-making process among the central government and local government. Sometimes the minister, Yasutoshi Nishimura, he is in charge of the coronavirus, had some argument with the governors of Osaka and sometimes with the Tokyo. Why this sort of a kind of confusion happened to those the decision making and the implementation of our emergency policy itself? Next slide, please. And I myself, in this April, I wrote the article on Gaiko diplomacy published by the Ministry of Foreign Affairs, in which I mentioned that several points of the weakness of our emergency decision making. The one is the lack of the control tower function of the cabinet secretariat. Actually, the officials in charge of the influenza did not recognize themselves as a core, the official in charge of the emerging, the risky infectious diseases in this January. And even the officials in charge of the infectious diseases of the Ministry of Health did not realize the COVID-19 became such a serious the cause of the outbreak of the infectious diseases in the later part. Why this sort of things happened is the lack of the control tower function of the cabinet secretariat. We don't have the CDC like the United States of America, even though we have a wonderful political leadership under the Prime Minister Abe. We did not have the real bureaucratic support for the decision making through the systematic, the function. And the second is the lack of the new factors, the creating functions for the clinical and the pathological analysis and testing and epidemiological surveys and international cooperation. We have a National Institute of Infectious Diseases, but this institute has not such a function like a CDC, and very small the function this institute has. Even though this institute is the headquarters of the local, the Institute of the Infectious Diseases and the Institute of the Public Health Services at the community level. And through our experiences now that we did realize that how the epidemiological research should be closely related to the clinical research. But unfortunately, even though the location of this institute, of National Institute of Infectious Diseases, is located just beside of our National Institute of the International, the Global Health and the Global Collaboration, which has the wonderful affiliated hospital, and which was the headquarters of our clinical research of this COVID-19, those of the institutes did not have any collaboration actually under such an emergency. Why this sort of thing happened is a very fundamental question to overcome the bureaucratic barriers. The third is securing dedicated hospitals and the required sick beds for emergency infectious diseases. It was very fortunate. We had a wonderful, resilient health system and the universal health coverage. Therefore, we did not have such a wonderful preparation for the risky infectious diseases at that time. We could quite efficiently and flexibly cope with the emergency needs through the very resilient health system. But we should shape up it, and then under the emergency. And fourth is the clarifying the division of the roles between the state and the regional government, as I mentioned earlier. We did not have the chain of command under the emergency for the infectious diseases, unfortunately. So we have to clarify the role of the local government and role of the state governments. For example, local institute of the infectious diseases belongs to the local government. And of course, the Institute of the Public Health Services, of course, affiliated to the local government. Those of the institutes affiliated to the local government cannot be efficiently collaborate with the central government under the command. This was the fact we faced. And fifth is the legislation for the infectious disease emergency. We have specified law for the infectious diseases, but it was not enough to cope with this sort of a very, very, the strange and the difficult, pathogen of the COVID-19. So we should prepare to propose the new legal framework for the infectious diseases at the regular session next year. The sixth, the creating a healthcare information system on an individual basis. Unfortunately, we noticed that we don't have those are the healthcare information systems on the individual basis. As a result of the lack of this system, the central government cannot collect the right kind of the information of the infected cases from the community levels. Therefore, this is the very serious subject we have to overcome. And the next, please. And then I, as the chair of the subcommittee for infectious diseases and the governance of the LDP, I proposed my own idea as a fundamental reform for infectious diseases and adopted by officially the LDP and proposed to the government, new Prime Minister Suga. So we start to reorganize and shape up our new, the system for the emergency from the regular session next year. Thank you very much.
Thank you for that wonderful presentation. If I can sum it up, if you'll allow me to sum it up, it's basically Japan has done a very good job, but there are all sorts of problems. Lack of bureaucratic support, lack of CDC, lack of collaboration across bureaucracies, conflicts between the state and prefectural government, lack of a good legal framework, lack of effective information system, and these are all proposals that you want to fix going forward. That's so right. We're going to hear now a very different perspective from Professor Estévez-Abe, who, at least in her paper, tells a story of bureaucratic, and her excellent paper, which I recommend, tells a story of effective bureaucratic reactions. Margarita?
You need to unmute yourself.
Sorry. Thank you very much, Michael. And thank you, Takemi Sensei, for a wonderful presentation. And thank you very much for having me here today. So the photo on the right side of this slide comes from my article published in Newsweek Japan on July 14th. I'm not responsible for this grandiose title, elderly facility is the reason for Japan's Japanese sort of victory. For commercial publications, it's always the editor that picks these titles. There is also a forthcoming academic paper in English, the one that Michael has kindly referred to, and I believe that it has been uploaded onto the website of the US-Japan program, if any of you are interested. So this article, I may also add that when the Tokyo Medical Association gave a high-profile press conference at the end of July, the vice president, he basically made a presentation on the successful control of COVID-19 in Japanese nursing homes based on my article. So I was very pleased that just some of the Japanese experts also agreed with me. So this was, okay, so let me just go ahead. Oops. So let me just briefly just talk about why I came to write about the nursing homes and the COVID-19 in Japan. So back in March, I was extremely worried about Japan. So, so at that point, I didn't think that Japan was going to do well. And in fact, despite the fact that someone like Jeffrey Sachs, he was just writing, he wrote this article about the East-West divide in COVID-19 control, basically observing that East Asian countries, including Japan, just seem to have much fewer deaths from the new coronavirus when compared to Western countries. Even when this was published on April 8th, I was still certain that Japan was just going to be the East Asian anomaly, and that would become more like Europe or the New York City. Why? In my view, the Trump administration and the Abe administration in Japan were reacting to the new virus in a very similar way, which was just doing very little. And especially these two countries were just very slow to increase their testing capacities. The situation changed in the US since, but the situation hasn't changed that much in Japan. So April passes by, May comes, and finally the population dynamics data at the prefectural level just became available. So I just checked the death tolls. I just looked into the excess number of deaths in the greater Tokyo in March and April. And when I saw that the death toll was actually small, that I had to accept that Tokyo wasn't becoming the next New York City. And instead, I just started just looking into why Japan could contain the virus. So here in March, it became very clear that those countries that just ended up having a lot of death from the COVID-19, they tended to experience lots of infectious clusters in nursing homes. And now just European countries, so this was true in many European countries like Italy, Spain, and this was just true in the US, in many states within the US, New York City, Massachusetts being one of those. And most advanced industrial countries are just very old, demographically speaking, and Japan particularly so. And we know that the COVID-19 strikes the elderly hardest because the elderly people, especially those in nursing homes, tend to suffer from comorbidities. So just to give you an idea, in Japan, the percentage of those older than 80 years of age is almost 10%. Germany and Italy are the next in line, and these are the countries that are just very old, demographically speaking. Just compared to the US is just relatively younger. And also when we just look at the percentage, the percentage of people who died from COVID, in most countries, we just find the majority of them are just quite old people. And also when we just look into the percentage of nursing home residents among those who died of COVID-19, as sort of Michael just referred to this at the very beginning, in the US, it has been just the majority of people who died would be residents of these nursing homes in some of the states. And even Germany, which is just considered as a Western model case of handling the COVID-19, even in Germany, 45% of those who died died in nursing homes, whereas in Japan, the percentage has been just very small. So I just thought that maybe the key to understanding why Japan was capable of minimizing the number of deaths may perhaps just lie in the nursing homes. Okay, so so this is a just very brief presentation. So let me just briefly talk about this. So it turns out that by mid-February, many nursing homes in Japan were already in lockdown, particularly in the greater Tokyo area. So lockdown meaning that the families couldn't visit their parents. People who were, all the service people who were just bringing in supplies to these facilities, they could not enter the facilities. That all the sort of handing over of deliveries would take place outside of the facility. Whereas when we just look at the US imposed lockdown on nursing homes only in mid-March. And many European countries did it in mid-March or even later. So it turns out in retrospect that the Japanese nursing homes went into lockdown very, very early. And now just some of this or much of this didn't have anything to do with a special COVID-19 strategy. So in Japan, what was important was that this was just part of the routine prevention and control system. Especially during the flu season, the Japanese nursing homes go into alert mode when it comes to prevention and control. So Japan got lucky that this hit Japan during the flu season. And here there are some sort of interesting sort of differences in the routine prevention and control. The Japanese nursing homes or Japanese sort of medical sort of professionals, they rely on face masks during the flu season. So in Japan, wearing a face mask is part of the routine of trying not to catch the flu virus. Nursing homes in Japan, they're used to limiting visitors during the flu outbreaks. So these were just nothing. So the things that the Japanese nursing homes were used to doing during any flu season, these prevention and control measures just happened to work against the new coronavirus. And this is interesting because in the United States, for instance, nursing homes are not required to use face masks during the flu season. In the US, the strategy is vaccination, flu vaccination. So in the United States, you're vaccinated, well, all nursing home workers have to be vaccinated and the residents too. Hence, the idea is that since everyone is vaccinated, no one has to wear a face mask. So you can just see how these different sort of routine prevention and control measures had sort of created a particular context when the new virus arrived. And also it just happens that in Japan, the average size of the nursing home facilities is much smaller than in Europe or in the US. So when there is an outbreak of infection, the number of people who would be affected is just significantly smaller in the Japanese case. So in Japan too, there have been infection clusters, but they just tended to be much smaller. And so there was also a very important bureaucratic routine. So there was a mid-level reaction within the bureaucracy that just that ended up being very effective. So as early as late January, the first tsuchi of the first sort of administrative notice from the Ministry of Health, Labor, and Welfare goes out to all nursing home facilities, alerting them that there is a new virus and that they should just go on the the most sort of careful sort of stage of prevention and control sort of routine. And on February 24th, the ministry basically just orders nursing homes to just go into lockdown. But as I told you, just many of the facilities were already on the lockdown mode. So when the February 24th order came, so this is when just everybody else just sort of went into lockdown. And the note is, so Japan, just when it comes to nursing homes, so Japan was very different from a country like the United States, in the sense that there is a bureaucratic organization that's exclusively and solely sort of dedicated to nursing homes or elderly care. Whereas in the US, just nursing home, the oversight, the bureaucratic structure related to nursing homes is just divided. It's not just decentralization between the federal and the state and the county, but also across, across sort of departments. Okay, so it's just very, very, very chaotic. So in Japan, in contrast, when it comes to nursing homes, there was a more streamlined bureaucratic structure and bureaucrats whose task was to worry about elderly care. Hence, we just see these early sort of notices just going out to nursing homes. And also, I can just probably just talk about this sort of later, but the bureaucratic structure was hierarchically organized when it comes to top-down information. And with the help of trade associations of elderly care facilities, the message from the top would just reach down to individual nursing homes relatively effectively in the Japanese case. The information didn't travel back up, but it did just go back down.
Margarita, in the interest of time, can you take one more minute and finish up, please?
Yes.
Thank you.
So here's the slides. I'll just stop with this. So the lockdown and all these Japanese sort of routine prevention and control systems worked in March, April, and May. But lockdown is not the answer for as a long-term prevention and control. And the fight against the COVID is a long-haul fight. And so the Japanese method that worked, so that wasn't a solution for long term. Japan's still not testing. And from July, there has been an increase in the number of infection clusters emerging in nursing homes. So the success, what seemed like a success story may not end up being a long-term success story. And I'll just end here. Thank you.
Good, thank you very much. So the key to understanding the Japanese puzzle is the nursing home low level of deaths. And that is the result of standard operating procedures in the bureaucracy, the structure of the nursing home industry, vertical controls issuing from the ministry, those guys sitting there working hard late at night, trying to figure out how to deal with the epidemic and disease in nursing homes. Thank you. But it's not over, warns Margarita. So next we turn to Aya Sensei, Goto Sensei, who will provide us a perspective on what has happened in the communities.
Okay, let me open my slide. Right. Thank you very much for this opportunity for me to talk about Japan's response to COVID-19 at the community level. I'm just right now surprised that what I'm going to talk about the community health nurses in community, public health nurses in community, the story of it is very similar to what we have just heard about welfare workers at elderly care facilities. So let me start. Okay. Just briefly about myself, I was trained in obstetrics and gynecology a long time ago, but now work as a public health doctor in community. Usually at hospitals, doctors and nurses diagnose and treat patients. But in Japan, we have a unique public health system that public health nurses and doctors work together to diagnose community using mainly the government statistics and prescribe health policy and health promotion activities. And the number of doctors and nurses in general is 1 versus 4 in Japan, but in public health, the ratio is 1 versus 17. So you'll know that the main actors in community are the public health nurses. What they do are, like in the picture, they do health parenting counseling. In the picture on the right, I'm helping nurses do the community diagnosis and planning of health promotion activities. And this public health nursing system was established in 1941, very early, well before the universal health coverage, which is national health insurance, a system that all people can access to quality health services at an affordable cost. That was achieved in 1961. And these nurses, they're trained within a 4-year nursing education or in a 1-year advanced program after graduating a nursing school. Let's look at mothers' anxiety toward COVID-19 in Japan. My talk is mainly about mothers and their children. Our group, led by Aichi Medical University, did a survey on behavior changes among the general public in May this year. The survey regions are marked in green on the map. From the north, these are Fukushima, Tokyo, Aichi, and Kagoshima. Today I am in Aichi, and the principal investigator, Dr. Kota Suzuki, is joining this event with me. The response rate for this survey was 65%, which is surprisingly high for this type of mail survey without reminders. It shows a high interest among people on this topic, of course. And for my part, I extracted and analyzed mothers' data. And I found out 70% were clearly worried about the COVID-19 and 30% were even horrified. And these are the mothers' free written opinions who are especially worried about the COVID-19. One mother wrote, "I feel horrified because it is caused by invisible virus." Another one wrote, "I feel sorry that I won't let my child run outside in a park but cannot because of the fear toward corona." And it was really interesting that we heard many things about television, and one mother wrote, "I'm worried that I cannot distinguish which information is true and which is not." And actually this situation sounds very familiar to me because of the experience we had after the Fukushima nuclear accident in 2011. You see, both virus and radiation are invisible risks. And around that time, we analyzed public health nurses' parenting counseling records and their peer discussion notes. And one nurse wrote that mother is worried about and cannot let child play outside. She's worried about her child licking the sand. And in the peer discussion, another nurse wrote that it is important for mothers to think by themselves based on accurate information. And she went on to say public health nurses are their close advisors. So let's look at public health nurses' response to COVID-19. For this purpose, I met with 3 public health nurses in the picture whom I often work with. They talk with residents with symptoms and worries, mainly over phone, refer them to testings when necessary, and do contact tracing of positive cases and provide support to patients till they return back to their daily life. And they said that they were extremely busy from March to May, and it was difficult to manage regular work. And they repeatedly told me that phones started ringing soon after they finished the call and placed the receiver. And this picture shows a nurse calling and cabinet full of filled forms to record about the calls. And I think this tons of files illustrate a part of the problem, the issues that Dr. Takemi pointed out about not digitalized information. I also asked them about their positive views of their own work. In Japan, every pregnancy is registered, and a pregnant woman receives receives a maternal and child health handbook at a health center. And this pregnancy registration is now becoming a good communication opportunity for nurses to listen and respond to women's worries. And another point that a nurse excitedly reported was that they first conducted a COVID-19 workshop for women health instructors in community. And this has been expanded by requests from other citizen groups. And they organized 26 sessions and 632 residents participated so far. So you see that they incorporated activities for this new crisis into their existing work frame very wisely. And when I asked about how they applied the lessons learned from the nuclear accident, they first mentioned about the city's response policies for a new crisis. This was developed after the accident, and luckily, the definition of new crisis included infection. So this allowed all nurses to work together regardless of their allocation. And the second point was residents' compliance to the new situation. They do not want to repeat the stigma that they themselves experienced after the nuclear power plant accident. And also, luckily, they are used to wearing masks. And the third point mentioned was that the information flow is much smoother this time. And this is one of the example of the government leaflet. It recommends people to avoid closed spaces, crowded places, and close contact settings. And many messages are clear, and you can see that they use illustration effectively. Well, this is going to be my last slide. In Professor Reich and Dr. Takemi's book for local health governance, they ask two key questions. One is how to cultivate meaningful community participation, and second, who does the work? Below are my answers for this COVID-19 case in Japan. We need to find ways to respond to a new crisis within the country-specific system and balance prevention and daily lives. And in Japanese health system, I think that public health nurses are the key to bridge medicine and community. They're the health professionals and they live in the communities. And this picture taken at an elementary school where I worked last week illustrates the balance between schools' efforts for social distancing by marking on the floor and how children actually do the cleanup at the end of the day. It is difficult to find the single ideal solution that can be commonly used in all countries aiming for zero risk. That's impossible. So we need to find our own ways to respond to this COVID-19 crisis. Thank you.
Thank you very much, Aya-sensei. That was a super presentation, and it's great to have both the pictures and the words of people from the front lines, both the providers as well as the mothers. And I think, you know, your answer to the puzzle is public health nurses, that they're connecting the public with the medical care system in ways to help provide community responses, community control. So people are welcome to put questions in the chat. We have time, we have 15 minutes left. We can take 2 or 3 comments or questions. I'd ask people to keep them brief if anyone has a question. They can raise their hand, they can put a note. Is there someone who has a question?
Michael,
Susan?
Susan has a hand up, so yeah.
Susan?
Yes.
Christina as well, yeah.
Thank you really for that excellent panel. All of the panelists have emphasized the use of masks in Japan and also the effective bureaucratic procedures for prevention and control. So that seems to be a key point of the solution in Japan. In the US, in contrast, the focus now is almost entirely on the vaccine as the solution. What is the view in Japan of the vaccine? Do you see that as an important part of the prevention in the future? Is this going to be something that will be a national campaign to get the vaccine out there, or do you feel that is less important than these built-in ways of prevention and control?
Good. Let's take one or two other questions or comments. Shin, is there someone else who has a hand up?
Yeah, Christina has a hand up.
Christina?
This has been fascinating. And I would like to ask briefly, will Japanese move to have a digital agency promoted by Prime Minister Suga and encourage telemedicine, improve Japan's healthcare system? And I would be very curious about the role of telemedicine in light of the importance of nurses, community healthcare, and also the need for elderly to have access without being able to travel to medical facilities.
Good. The role of telemedicine in the future. Anyone else?
So
One
Michael,
more?
I'm just going to mention that Hillary Holbrow had a question in the chat about why Japan has not scaled up testing. So that seems to also relate to previous
Good.
questions. So
Good. So let's take those three questions. What's the view of a vaccine in Japan? How important is vaccine hesitancy, which has happened for the HPV vaccine in Japan, a tragic situation? What's the role? Why is testing so low in Japan? And the third is, what's the role of telemedicine? I would add to that, if you were to say to our current president in the United States, one lesson from Japan that he should take to heart, what would it be? So why don't we, with these, thinking again that the pandemic response really depends a lot on political leadership and the responses of political leadership. We'll go, again, our order for Takemi sensei, Margarita, and then Aya.
Yes.
Or maybe like two minutes or 2 or 3 minutes each.
Okay. The vaccines, we do realize that the really stable and efficient vaccine is absolutely necessary to end the outbreak of the COVID-19. And one of the cause of the fear of the people to the COVID-19 is that we don't have the absolutely efficient medical treatment yet. And in addition to the lack of the vaccine itself. So we have to sweep out the fear of the people. So in order to do that, we have to have the stable and efficient the vaccines, and we allow that every person who can access to the immunization for the new and the stable vaccines within the near future, I think. And secondly, the telemedicines, the temporarily under the COVID-19 outbreak, the government allowed to use the telemedicine as a tool for the routine, the medical care for the patients. But this is the temporary. But we do realize that we have to widen the space for those the telemedicines in the community healthcare services. Therefore, however, on the other hand, we are a bit worrying about that some medical doctors take care of the patient. A medical doctor itself live in the Tokyo, but the patients is far from Tokyo, Sapporo, in Hokkaido. So that sort of far distance can be allowed to use the telemedicine at the routine healthcare services. This sort of the conditions we have to prepare to carry out the new healthcare services through the telemedicine after the COVID.
And would you have a message for President Trump based on Japan's experiences? One lesson for President Trump from Japan?
Take masks.
take masks. Okay, we will send that to him. Thank you. Margarita?
Okay, just briefly, just on the telemedicine. There has been a change. Telemedicine has just become possible in Japan, and that was just one thing that happened out of this sort of pandemic. But Japan is a digital laggard. So old people in Japan wouldn't know how to do this. And this also is just linked to the fact that Japan has been a North Korea of public COVID data. It's really embarrassing that we just have so little information on the actual scope of COVID-19. Partly this is just because there's been just so little testing, but the data not even digitalized. So this I really would like to ask Takemi sensei to do something about this, because Japan just really looks like North Korea when it comes to publicly available COVID data. Testing, it is great sort of question on testing. Probably Takemi sensei just knows, would be the best person to talk about this. Some people just say that this is just because of the regulations that Japan has. But it's really sort of mystifying, but it also just had something to do with the hokenjo, the public sort of health sort of facilities that are in charge of collecting data, not being able to process data on infected people. So they don't want much testing because they can't really deal with the data. So there's just something very serious going on. So far, ordinary Japanese people have dealt with this, especially in nursing homes. Just care workers who would even don't go out with their friends so that they wouldn't contract viruses and bring it back to the facilities. I mean, this is not a long-term solution. Testing is necessary. Nursing home facilities are begging for more testing, and it's still not happening.
Good. Thank you very much, Margarita. Aya?
Yes, about the vaccination and testings, I think these are being the hopes for the general public to bring things back to normal. But from, professional perspective, I think these are less important than built-in Japanese specific ways to tackle the problem. So that's my one answer. And about the number of the testings, I think to best utilize the Japanese system, especially the hokenjo, in order to increase the positive predictive value and use the very effective contact tracing system, we need the minimum medically necessary number of the testings. However, we don't need the wider number of the testings to be distributed to accessible to people. I don't think that's necessary. And about the one message to your president, I would say listen to the community health workers.
Good. We'd actually like him to listen to any of the scientific experts who actually understand epidemiology and pandemics. Keizo, can we end with a question for you?
Oh.
And so what's going to happen with the Olympics?
Oh.
Is Japan really ready to open up internationally to take people from all around the world with adequate safety and control for the Olympics?
That our government, in collaboration with the International Committee of the Olympic, determined to organize the Olympic and Paralympic the next summer. This has been already decided, but we know there are so many obstacles emerging, and the political decision was made. However, we have to overcome so many difficulties, and then several uncertainties are still exist in front of us. Therefore, I cannot say clearly we can organize the Tokyo Olympics next year. We, however, as a parliamentarians, and we decided to do that and do the best for that. That's our position. But of course, try to do our best to organize it in the most safety manner and protect the outbreak of the infectious diseases at the time. So this is the challenge of our government and our people. I hope this challenge can success and show the first case of the Olympic, which can be taking place under the outbreak of the infectious diseases. This is a challenge, Michael.
Good, Keizo. Well, I think that we all appreciate your efforts as a member of the leading party, your efforts as a global health expert yourself to help us understand what's happening in Japan and to use this as an opportunity to improve the various systems problems that exist in Japan. I don't think that we've come to a conclusion today about the puzzle and the solution to the Japanese puzzle. I think, from sitting in the United States, we all feel Japan has done so much better than our situation on almost any metric that we can think of. And I think we've heard that part of it has to do with the national level government response. Part of it has to do with the way that the bureaucracy has worked in controlling the potential for outbreaks in nursing homes. And part of it has to do really with the foundations of the public health system in communities, especially the role of public health nurses and the Hokenjo, the public health centers. It's not over yet. We're going to be living with this virus for a while, and we're going to need a continuation of efforts from the top, bureaucratic systems in the middle, and community mobilization and experts embedded in the communities at the bottom to really get control. If I were to say something to our president, or at least to the people in the administration, it would be that you need all of these different efforts working together if you're going to have effective and sustained control over a period of time. So I'd like to thank our panelists. I'd like to thank everyone who participated, and we'll end on time. Shin, do you have any last?
Nope.
Christina?
Thank you very much. My recommendation to President Trump is he learn from other countries' examples.
We could ask him to learn from his own experience as well.
Thank you all, Professor Reich, for bringing us together, our panelists, and of course, Takemi Sensei staying late at night to be the last at the House of Councillors building. Thank you all very much.
Thank you.
Okay.